So we are ready to start. Dear participants, I'm Dr. Julia Zając, and I have a great pleasure to welcome you at the third topic on focus Thrombotic Microangiopathies webinar. This program was developed in collaboration between EuroBloodNet and CNR-MAT and consists of 15 sessions. Furthermore, the program has been accredited with 11 continuing medical education points by European Board of Accreditation in Hematology. And dear audience, please welcome with me today's speaker, Professor Ygal Benhamou, who will lead the session on diagnostic workup for TTP and TMA syndromes, pitfalls. Professor Ygal Benhamou graduated in medicine in Rouen University, France, and he obtained his PhD in pharmacology. Since 2016, he has been nominated as a professor of internal medicine at Rouen University School of Medicine. He is currently head of the internal medicine department of the Rouen University Hospital, and he is a member of the National Reference Center for Thrombotic Microangiopathies, and also coordinates the Regional Reference Center for Rare Vascular Diseases. He is co-author of the French guidelines for venous thrombosis diseases, and moreover, he's an author of over 100 articles in peer-reviewed journals. Professor Benhamou, the floor is yours.
Thank you very much, July. Hello, everybody. So I'm going to switch off my camera because I used the microphone and it's not so easy to do the both things together. So excuse me for this. Okay, so hello everybody. It's a pleasure for me to be virtually with you to speak about the diagnosis of TTP and TMA syndromes. And it's very important to make a focus on some pitfalls that sometimes lead to delay before the introduction of specific treatment. So, is it okay? Yeah, it's okay. Here are my disclosures. And so let's start. So my talk will try to answer to this fundamental question is what do we need to improve diagnosis in TTP? And in my opinion, the first step is to know the definition and classifications of TMA. And as you can see on this slide, this is a new classification proposed by Jim George. And they tried to make a similar classification between TTP and between complement-mediated TMA that we previously named typical hemolytic uremic syndromes. And as you can see now, we have hereditary TTP, acquired TTP, hereditary complement-mediated TMA, and acquired complement-mediated TMA. This is the two major TMA. But we can see also the drug-mediated TMA, the Shiga-toxin-mediated TMA, and metabolism-mediated, drug-mediated TMA by immune reaction, and coagulation-mediated TMA. And this is very important, this last point, because you know and you listen about the thrombotic burden after vaccination against coronavirus, and sometimes we believe that the coagulation-mediated TMA is one of the major actors of this thrombosis.
webinar attend
Okay, if you make a focus on TTP, you have to know also the definition and the clinical presentation. And TTP is a biological and clinical syndrome associated by, defined by the association between mechanical hemolytic anemia, peripheral thrombocytopenia, organ failure of variable severity, sometimes brain, sometimes gut, sometimes lung, and every time with a severe ADAM13 deficiency. This deficiency may be due to congenital abnormalities and especially with a failure on the gene encoding for ADAM13 or by immune mediated by the secretion and the production of autoantibodies against ADAM13. And in one case, this is a Upshaw-Schulman syndrome, and in the other case, this is a Moscovich syndrome, more frequent in adults and especially in women. The second step for me is to know the distribution of the different TMA, and the data from this French retrospective study, included more than 500 consecutive patients, show that most of TMA are secondary in almost 90% of cases, and especially related to pregnancy, to drugs, to cancer, or to infection. And the primary TMA is frequent in only 6% of cases, with an equal repartition between TTP and hemolytic uremic syndromes. The third step is to distinguish all the TMA, and this is an old view and of course a wrong view, because sometimes we believe that TTP is always with a presentation with neurological disorder, fever, cardiac disorder, as hemolytic uremic syndrome will present mainly with renal failure or gastrointestinal impairment. However, some recent data suggests that there is an overlap between these two major TMA. And as you can see on this slide, when we focused on the extrarenal clinical presentation of a typical hemolytic uremic syndromes, we can see when you compare adult and pediatric patients, just a moment, yep. We can see that neurological involvement impairment is more frequent in adult, and it's a very important key message for physicians, especially when you work in intensive care unit, because in front of patients with a TMA syndrome, biological TMA syndromes, and if you have a coma or epilepsy, it's not so easy to decide to start eculizumab or sometimes plasma exchange. So you have to keep in mind that sometimes in atypical hemolytic uremic syndrome, you can have neurological syndromes, gastrointestinal syndromes, but also cardiovascular or pulmonary syndromes. The step 4 of the discussion, I think, is to know the area for improvement in diagnosis of TTP. And we have to respond to this question: what do we need to improve in TTP? And according to me, there are two points of view. The first one is how to better identify patients with ADAM13 activity less than 10% from D1 at the emergency room. And the second point of view is how to identify patients at high risk of early days. How do you have any tools to recognize most severe patients? So, if you have to respond to this question, we have to make a reference to this article, because in France we have developed the French score based on the result of this retrospective analysis published 15 years ago. And we compared in this work patients from the National Register with a TMA according to their level of ADAM13. So in the left column, we have patients with ADAM13 activity less than 5%. So it's patients with TTP, and another patient with TMA without confirmation of TTP. And what is interesting in this slide is that the main significant differences observed were the lower platelet count in patients with TTP, a lower level of creatinine in patients with TTP, and the more frequent presence of antinuclear factors in TTP as compared to other TMA. And in a multivariate analysis, we adjusted odds ratio were calculated, and as you can see, the creatinine level was the strongest factor associated with a deficiency in the severe deficiency in ADAM13. It's the same thing for platelet counts and as for positive antinuclear factor. And therefore, if you have two factors of among these three factors, and especially if it's platelet count less than 30 giga per liter or creatinine level less than 200 micromole per liter, we can confirm the presence of a severe ADAM13 deficiency in more than 90% of cases. Of course, in the same way other SCORE and other teams developed other score with new biological parameters such D-dimer, so bilirubin. And according to me, the most accurate score, other than ours, is the plasmic score with 7 points. And if you make a comparison between the French score and the plasmic score, the first difference is, of course, the number of parameters, because in the French score, we have only 3 parameters, as in the plasmic score, we can find 7 parameters. And the second point of the second difference, excuse me, is that in the French score, we can apply this score, apply and use this score when you have a TMA without specific medical context. Of course, if you have a pregnancy or cancer, graft, sepsis, or chemotherapy, the French score is not validated. And it's the same thing for the plasmic score. So the question is not to know if the plasmic score has a better performance than the French score, but is to know where you can find, where we can use, excuse me, the French score, the plasmic score. So if you have a severe thrombopenia and the middle renal failure in front of a TMA syndrome, you can confirm the presence of a severe ADAM13 deficiency in more than 90% of cases. And it is important because maybe you are read the publication from the Hercule study with the caplacizumab, and for include patients, we can use the French score, and it was one of the inclusion criteria in the study. So we have not to wait for the confirmation of the ADAM13 activity before introducing caplacizumab or to consider patients with a real TTP. The second part of my talk is to understand why when TTP patients still die at the acute phase. Of course, we learn how to manage these patients at the acute phase with daily plasma exchange, corticosteroid, the use of rituximab in frontline, and more recently, the use of caplacizumab. But mortality is still around 10%, not 15%, but around 10%. And we have to know why these patients still die from their TTP. And here again, we have 2 points of view. The first one is to understand and to know how to reduce misdiagnosed TTP that sometimes lead to a delayed management. So we have to make clinicians more aware of TTP diagnosis. The second point of view is to recognize most severe patients, and sometimes we need to intensify treatment in this patient with coma, especially, or with great neurological disorder. So we have to recognize these patients. So the step 5 is how to reduce the misdiagnosed TTP. And as you can see in the slide, we conducted 4 years ago a retrospective analysis of patients issued from the French Thrombotic Microangiopathies Reference Center, and we include 423 patients with acquired TTP. And when we observe the initial management of these patients, we were surprised because in 20% of cases, patients had misdiagnosis, and accurately diagnosis group was in 80%. So the question is, what about misdiagnosed patients, and what are the cause of this misdiagnosis, of this diagnostic error? And when we search the different parameters associated with a diagnostic error in a multivariate analysis, we find that positive direct antiglobulin test was strongly associated with a diagnostic error. And it's not so surprising because, as you know, in TTP, the association with autoimmune disease is around 15% of cases. So when you are at the emergency room and you have a young woman with anemia, thrombopenia, and a positive DAT, of course you believe and you trust that the diagnostic is even syndromes, maybe with lupus, and you don't think at the first time on a TTP diagnosis. The other alternative diagnosis observed in this study was immune thrombocytopenia and antiphospholipid syndrome. The second parameter strongly associated with a diagnostic error was the low or undetectable schizocytes on the first blood smear. And in this study, it's interesting to know that more than 30% of patients had not schizocytes on the first blood smear. So the physician should repeat the different measurement to show and to recognize schizocytes. Of course, if you make a diagnostic error, patients with a misdiagnosis had a longer time before the recovery of platelet count and the normalization of the platelet count. But by chance, we didn't observe in this study no more deaths. Another medical situation leading to a diagnostic error is the pregnancy. And for me, the most important point and the most difficult situation for a physician to decide about specific treatment. As you know, during pregnancy, there are various TMAs with similar presentations. We have some specific TMAs, such HELP syndrome, preeclampsia, or non-specific, such TTP. And with a similar clinical presentation, despite a distinct pathophysiology, we have to conduct a specific management. And it's very, very difficult for a physician when you have a woman at maybe 26, 28 weeks of pregnancy to decide the specific treatment, because in one case you are going to start plasma exchange, and in the other case, especially during the HELP syndrome, you have to provoke the delivery. And it's not the same prognosis for the mother and of course for the baby. So I believe you are going to have in this educational program a specific session on TMA associated with pregnancy, but I would like to insist on this slide. And of course, it's an unpublished data issued from the French National Reference Center, but it's important to know that when we compare patients, women pregnant with TTP and HELP syndrome, of course, fever was more frequent in TTP. Anemia was more profound in TTP, but platelet and creatinine were comparable. And the main point is that the ratio between LDH and ASAT was comparable, and this is in contrast with recent publications that insist on the impact of this ratio to determine HELP syndrome instead of TTP. And on the right side, you can see that when we measured ADAM13 activity, of course, in TTP patients, in all cases, the ADAM13 activity was less than 10%, but in HELP patients, or in the presumed HELP patients, 6 of the 40 patients had ADAM13 activity less than 10%, and the final diagnosis was not HELP syndrome but TTP. So just imagine if in this case you provoked the delivery and not start the plasma exchange. So I think it's important to understand that ADAM13 activity is the only one reliable marker to distinguish TTP from severe HELP syndrome. One other pitfall is, one other pitfall is how to recognize sometimes TTP with Pseudo-TMA. And this Pseudo-TMA is most often related to pernicious anemia that sometimes mimic a TTP. Why? Because sometimes we can find on the blood smear some schizocytosis. It's not a real schizocytosis, but sometimes you can have this result on the blood sample. And when you see this slide with the recent publication from the French National Center, when they compared patients with Pseudo-TMA and TTP, it's interesting to know that, of course, there are biological differences. And the hemoglobin was lower in patients with a pseudo-TMA. Reticulocyte count was lower, platelet count was higher, neutrophil count was lower, and LDH was dramatically increased in patients with pseudo-TMA as compared to TTP. And this pseudo-TMA is often we can observe this pseudo-TMA because there's an intra-bone marrow hemolysis in deficiency in vitamin B6 or B12. To conclude with the pitfall, I think it's important to insist on the presentation in TTP in the elderly. And as you can see on the title, keep your mind open for unusual presentations, because the recent publication from Prevalence, this is the data from our group published in Blood last year. When we compared patients with TTP according to their age, less or more than 60 years old, we can see that some clinical differences between the two cohort of patients. And sometimes delirium, seizure, behavioral abnormalities were more frequent in patients older, and especially platelet count, hemoglobin, plasma creatinine were different between these two groups of patients. So when you have a patient of 70 years old with an anemia and thrombocytopenia, you don't think at the first time to TTP, and sometimes you think about myelodysplasia or something like this. So you have to know that patients with older patients with TTP may have an unusual presentation, clinical and biological presentation. And the second message of this paper is that TTP in older patients had a higher 1 month and 1 year mortality rate. And when we compare the mortality of this patient with a general population with the same age, we observe that it was negatively impact life expectancy in survival. So patients with TTP with the same age that other general population had a shorter life expectancy. The last part of my talk was how to recognize the most severe forms of TTP. Of course, most deaths occur in the first 2 weeks after diagnosis, mainly in the context of uncontrolled TTP. So the question was, is there a profile of patients whose outcome is worse? So we conducted a retrospective analysis 10 years ago, and we included 248 patients. And when we compare patients between the 27 early days and the 221 survivors, and when we try to determine some factor associated with early days during the first months after the management of the acute phase, in multivariate analysis, we were surprised to find three major parameters. The first one was cerebral involvement, with a strong association with deaths of refractoriness. The LDH level, when it was higher than 10 times of the normal range, and the age, and especially for patients older than 60 years old. And then after we establish a score with a ponderation, and we put 1 point for cerebral involvement, 1 point for the LDH, 1 point for the age range from 41 and to 60 years old, and 2 points for patients with age more than 60 years old. And the validation of this score shows that the mortality rate is different between patients with 2, 3, or 4 points. And as you can see on the right side of the slide, patients with 4 points had 66% of mortality. And it's very, very high. And this point is very important to sometimes decide to intensify patient therapeutics treatment in patients. The last point to recognize most severe patients is the involvement of the heart injury during TTP. And we and others have assessed that sometimes when you have a heart injury, and especially when you have elevated troponin level, we can have worse prognosis. And on this retrospective study, including the 133 patients with acquired TTP, we showed that troponin level greater than 0.25 microgram per liter was strongly associated and importantly associated with refractoriness or death, and this was independent for the precedent severity score, included age, LDH, and neurological involvement. And on the right side, you can see that there is a linear correlation between the level of cardiac troponin and the occurrence of days of refractoriness. So patients with the higher rate of troponin had the worst prognosis. So troponin is, according to me, but it's the opinion of the general physician who knows about TTP, it's a really reliable marker of severe disease. So to conclude, I would give you this take-home message. First, TMA is a common medical disorder with a severe prognosis when specific treatment is delayed. So you have to reduce misdiagnosed TTP. Predictive rules are available to identify patients with severe deficit in ADAM 13, but you have to use these predictive rules in such in a medical context, except for pregnancy, cancer, or chemotherapy or sepsis. The prognosis assessment based on age, cerebral involvement, LDH, and troponin level is useful for personalized treatment, and sometimes it's a good help to intensify the therapeutic. And the last point is we have to be aware of certain clinical situations, especially pregnancy, and certain pitfalls that can induce misdiagnosis, such as vitamin deficiency. So learning by experience can be painful, but it is more painful not to learn from experience. Thank you very much for your attention, and do not hesitate to put some question on the chat. Thanks.
Thank you very much, Professor Benhamou, for this great presentation. And following your invitation to Q&A, I also invite all of the participants to write the questions in the chat.
So thank you for great. Thank you. What about the personalized treatment according to clinical presentation in patients with severe form? Oh, thank you very much for this question. Of course, with the different clinical tool and predictive rule of severe form and prognosis, sometimes we ask the question at the emergency room or during the first day in the intensive care unit to intensify patients with sometimes double plasma exchange or some cyclophosphamide use. But now with the use of caplacizumab, we think that the global therapy included plasma exchange, corticosteroid, rituximab, and caplacizumab try to correct the prognosis of patients. So now it's less of a priority for the physician to know the personalized treatment, because when you use all the available therapeutic, the prognosis of patient is excellent. And the last publication in Blood show that we have no deaths from TTP when you used all this therapeutic. Could COVID vaccine induce TTP? Yes, thank you very much for this question. Maybe you have read some paper with case report with TTP during COVID. I'm not sure that COVID-19 vaccine induced TTP, but we have some thrombotic burden, and this is all the matter with one of the three vaccine, and especially with AstraZeneca, and it's not related to the vaccine, but sometimes you can have some thrombotic without TTP. So to date, there are some TTP, but during COVID, but not after the vaccination. But after the vaccination, the matter is not the same. And maybe you have read the last paper with the VPIT syndrome. VPIT syndrome is for vaccination-induced prothrombotic and immune thrombocytopenia, and is more like heparin-induced thrombopenia more than TTP. How differentiate TMA with sepsis from TTP? So thank you. It's not so easy to make the difference between TMA with sepsis from TTP. However, during sepsis, we have other parameters such C-reactive protein, fever with high fever, because during TTP, the fever is not more than 38 degrees. So when you have 40 degrees with high CRP and with sometimes clinical signs of urinary infections or pulmonary infections, it's more easy. It's easier to make the difference. But I think it's not the major problem to distinct TMA with sepsis from TTP. The most difficulty is to make the distinction between sometimes anemia with secondary to vitamin deficiency or during pregnancy. Sepsis is not for me a real problem. Thank you for the presentation. Mortality rate is mainly driven by early mortality. Yes, of course. What about mortality associated with infectious complications to pronounce? Okay, this question is very difficult to answer, but thank you, Maya. Of course, the mortality related or associated with TTP is mainly during the first 2 weeks after the initial management. And now with the recent guidelines that recommend to use plasma exchange, rituximab in frontline, corticosteroid, and caplacizumab, we have shown, but the publication from Sanofi company and from one German team showed that we have a shorter time in intensive care unit because the use of this total therapy reduced the duration of patients, the duration of patients in intensive care unit, and we have less prolonged hospitalization. So sometimes maybe at least the immunosuppression is higher because we use for everybody rituximab and corticosteroid, but in the short period we have not more infection complication. Is there any difference between acute management of high suspicion TTP in pregnant patients? Yes, the matter of pregnancy is, according to me, the most difficult for the physician. And when you suspect a TTP during pregnancy, you have to start plasma exchange in the same way as in patients non-pregnant. So it's not a difference between the management of patients with pregnancy, without pregnancy, but the most important point is to recognize if it is a TTP or a HELP syndrome. And according to me, the only one reliable biological marker is ADAM13 activity. So in all other cases of TMA, we can wait for 2 days or 3 days before the confirmation of TTP. But during pregnancy, you have to get the result of your ADAM13 activity very, very quickly, because of course the specific management is totally different between these two major TMA. Thank you. No, no, there are no clinical score for TMA in pregnancy because it's it's difficult, and there's no clinical score. So you can help with different biological parameters. I showed you that the ratio between LDH and ASAT was not always useful, but sometimes it's a concordance of different clinical parameters and biological parameters. Of course, you can't imagine that it's during the third trimester of pregnancy, this is atypical hemolytic remix syndrome, because all the hemolytic remix syndromes occurred after the delivery. But for TTP, it's more difficult because the chronology between TTP and HELLP syndrome is the same, and it's during the second or third trimester of pregnancy. So sometimes you have to ask question with the patient, with the antecedent of patients, the clinical history of patients, and you can use biological parameters, morphological parameters, and sometimes you are going to start a plasma exchange session before the confirmation of Adam 13, and if you have a good laboratory, you can have maybe the result within 24 hours. This is the last question. Maybe there one more. How do you manage at the emergency room patient with suspected patients? Oh, yeah. So when you are in the emergency room and you have a TMA syndrome with anemia, thrombocytopenia, sometimes the key point, and it was the last experience of my young collaborators, that TTP is a thrombotic disease, and thrombopenia in TTP never lead, or also almost never lead to hemorrhagic symptoms. As in contrast, during pernicious anemia, and especially when the thrombopenia is profound, you can have some hemorrhagic signs. So this is the main difference, I think, between TTP and other TMAs, that TTP, it's always thrombotic event than in contrast to other TMAs. So this is the first point, to sometimes manage differently patients with a suspected pernicious anemia from TTP. And the second one is to get quickly the result of the vitamin dosage.
Thank you very much, and see you next time. Bye-bye.
Bye, everybody.